Welcome to the PODDocs. I'm Dr. Damien Dauphinee, and I'm here with my partner,
Dr. Raafae Hussain.
And we are going to be discussing plantar plate repairs or plantar plate tears and the dreaded crossover toe. Man, we've got entire days assigned to this problem at our national surgical meetings. The American College of Foot and Ankle Surgeons, there are whole days talking about, okay, what do you do about the crossover second toe? Because it's that hard to fix.
Yeah, it's a balancing act, and that's what people don't understand. They're like, oh, it's just a small problem. It's just toes. It's nothing big. But it's like you're trying to balance a tiny object using multiple tendons and trying to realign everything.
It's an incredibly unstable problem. And in some cases, in the elderly population, we just choose to amputate. I mean, it's for those folks, it's sometimes easier to take that second toe off. It's so dislocated. It's so out of position. All that you'd have to do to completely reconstruct the forefoot to get the toe back in place for some folks doesn't make sense. But we'll certainly go through that whole gamut here.
So, plantar plate repairs, aka crossover toes. So, what happens? Patients come in, they're complaining about pain in the bottom of their foot. They'll use like terms like, oh, it feels like I'm walking on stones. It feels like I'm walking on marbles. It's just so hard for me to walk on hard surfaces. And they won't have any calluses or anything like that necessarily. They'll just have diffuse pain, pinpoint pain, under the second metatarsal head, or whatever metatarsal. Usually it's the second metatarsal head, most commonly. We'll see some drifting of the toes, like you can kind of see here.
Yeah, the beginning of the end.
Yeah, and then as it gets worse and worse, it'll kind of cross over more. And commonly we'll see these in conjunction with bunions and hammer toes. But this plantar plate rupture problem is a specific problem that you do an additional procedure or additional surgery in conjunction to these problems. So a lot of the x-rays that we'll be showing here will show like bunion procedures and hammer toe procedures, but we'll point out what we're doing specific to repair the plantar plate. So what is the plantar plate? I mean, what's going on? So the plantar plate is the thickening of the plantar capsule pretty much under your metatarsal phalangeal joint. It's the articular surface cushion. So when you're hitting the ground, it's about 2 millimeters thick. It's nice and robust, and obviously with wear and tear, it can tear.
Exactly.
The hard part, like we were talking about, it has multiple attachments. The base of the proximal phalanx, the head of the metatarsal, but then in conjunction to that, you have the lumbricals. You have the plantar fascia, which attaches to it. The flexors run just under it, and sometimes we'll use those to act as an adjunct. And then we'll have the deep transverse metatarsal ligament coming across there. Aside from the suspensory collateral ligaments, we pretty much have everything attached to the plantar plate, and that's why it's kind of so difficult to treat these.
It's a complex balancing act between ligaments and the plantar plate holding that second toe where it's supposed to be, and when you have the great toe shoving it out of the way,
it's being bullied over.
Right, you can end up rupturing those collateral ligaments, and that's when you see the toe start to sort of spring over and pop over the big toe.
So commonly, the plantar plate, aside from the bottom portion tearing, the lateral collateral ligaments will start giving out also, and that's just due to the bullied nature of that toe kind of pushing it up, and then as you're walking on it, that rotated angle puts stress along those collateral ligaments.
And they either rupture or they become so stretched out that they're not doing their job anymore. Either way, you've got to utilize them.
Yeah, there's different classification systems and how bad these things are. We don't necessarily use them. That doesn't change the treatment options. But things that we're looking at, if there's so here's a picture of someone who monitored their foot, I think it was like over like a 5-year period or 4-year period, and they had pain. They watched that toe kind of drift over, and now you kind of see how it kind of just gave out, the lateral collaterals gave out, and the bunion is obviously crisscrossing under there. The deformity can present as a simple lift. You have the lack of purchase. Sometimes they'll do like that little paper pull test, you know what I'm talking about? It's one of those silly things, but I mean, it tells you if there's a lack of purchase. Obviously, if it's so far gone, obviously there's no purchase.
That's pretty easy to diagnose when you see that.
This right here, sometimes you'll see that lateral drift, the medial drift, more than you'll see the the plantar plate tearing and lifting up. You'll see sometimes that drift over. It's called the Churchill sign.
Or Sullivan sign.
Or Sullivan sign, yeah.
Yeah. And and Sullivan sign was really sort of, I think, popularized by looking at a space-occupying lesion in the third interspace, pushing the metatarsal heads together, and then allowing that second toe to drift where you get the peace sign. But, clearly in this case, it's more than just a Sullivan sign. You've got some instability at that second metatarsal phalangeal joint.
So let's go over kind of what's happening. So we have the hammer toe deformity, right? Pushing it back. Most common cause for this, hammer toes and bunions. That plantar plate gets overstretched. The plantar fascia is obviously pulling back on it. The metatarsals are trying to strum down, and that stretch of that plantar plate starts giving. That's where most commonly the plantar, the surface against the ground, that aspect starts giving out. The tendons and ligaments around it obviously will start giving out also, depending on the deformity, and if there's like bunion deformities or other foot deformities pushing it out. But the most common cause, the most common start to these problems is along the plantar aspect. So we'll get some imaging. We'll see what's going on. We'll see if we're missing anything. Commonly, all we're seeing is kind of the hammer toe deformity. You can kind of see it on the lateral and the obliques. Here you kind of see that lack of joint space, but what's really happening is that toe is kind of drifting up. So if you're looking at it from the top, you're kind of seeing that toe drifting up. So obviously, if you're looking at it like this, that joint space is overlapped.
But that in that picture there, I mean, that's an opportunity to intervene.
Yeah,
like
that's
if you fix that bunion deformity, fix the hammer toe, likely you'll be able to prevent that crossover toe completely.
Here you can kind of see how it gets worse and worse, that drift.
Yeah.
It looks like they had a bunion procedure in the past, didn't address the hammer toe deformities. Obviously.
Well, they may have. It looks like that second proximal phalangeal head's been removed.
Maybe.
But it didn't fuse, and they weren't able to stabilize the metatarsal phalangeal joint. But you can see the lateral collateral ligament is just done.
It's gone.
It's not doing anything.
Sometimes we'll get ultrasounds. Now, the trick with ultrasounds is very user dependent. So I don't like to rely highly on these. We'll get the imaging if we can. But most of the time the patient is too tender. You can't press on it. It's pressure from the ultrasound on there. But if you can and you're comfortable, you can kind of see this is the toe, right? Imagine the toe's out here. This is the second metatarsal head, the shaft going back this way. This is the plantar plate coming across here. And this gap right here, the hypoechoic area, that's the that fluid, what do you want to say, like
just the edema.
Yeah, it's the fluid showing between that gap. Obviously, if the gap wasn't there, you wouldn't have that fluid there. Here, this is the right side, left side. Left side, you can kind of see is the injured side. The right side, you have that nice healthy space. The normal joint fluid.
You can see all those layers really easily.
Here, this is the flexor coming across there. That's literally the flexor. That's the plantar plate right there. This is nice healthy plantar plate. This unhealthy plantar plate. So here, if you want to look, that's the flexor coming across here, flexor jejunum longus, and here's that plantar plate, and then the gap, and then here, the proximal aspect. I mean, it's nice kind of seeing that side by side, before and after type of thing. I put this picture here because it's upside down, and it kind of helps.
Yeah, that's how you'd see it from an ultrasound standpoint, exactly.
All right, so ultrasound aside, we'll get some MRIs. We'll kind of see what's going on. Hold on, I think this is ultrasound also.
Yeah, there you go.
Another ultrasound. So same thing. Here's a good anatomy kind of drawing of what we're seeing. Healthy, unhealthy, that plantar plate tear. That's that same thing we're looking at, that lack of continuity of that plantar plate coming across. This should be nice, healthy. Here you can even see chondrocalcinosis. Pretty much chondrocalcinosis is the calcification of the
ruptured
cartilage, whatever portion. Over time, if it gets angered, it'll happen. Same thing we kind of see with tendons, very common in Achilles tendons, where
you get mineral deposits in the tendon itself.
Yeah. And you can kind of see them on the x-rays and stuff, and obviously with the ultrasound. All right, MRIs. So MRIs are nice. They're very useful, depending on who you read. Just because it's such a small deformity, a couple papers have said between 95 to 70% visualization rate. So these, just because sometimes you can kind of get those thin slices, and if the slices are too thick, then it'll just kind of jump over.
You'll miss it, yeah.
Yeah. So whenever we order these, we typically will order like 1 millimeter slices in that area, just to make sure that we don't miss anything. So here you can see T1, that gap coming across here.
That should be continuous.
Yeah, that should be literally coming all the way to the end. Here, T2, I believe this is fat suppressed.
So we're seeing fluid in the gap.
Yeah, and that should not be there. Here, this is nice. They show the collateral ligaments also. This is what normal lateral collateral ligaments should look like. This obviously is gone. Yeah. This is kind of still there. You can kind of see that it has some slack on there just because how much it's drifted over. And then here you can see same thing. The medial collateral ligaments intact. Lateral collateral ligaments have completely gone. That's probably the area where it's literally ruptured, and they're getting that slice right through there. All right, conservative therapy. So there's not really much you can do conservative therapy-wise, and it does take a long time. Most of the papers show that between 3 to 6 months of conservative therapy, you may have some success. I mean,
you're trying to just get it to scar in okay.
Yeah.
And using the tape and padding to alleviate some of that positional problem, but I haven't found that to be very effective long term.
No. Just because you're walking on this, it's so hard. You have to understand. If this was your finger, we can strap that down. You're not walking on your hand. You're walking on these, and that's the hard part. Sometimes if you can immobilize them, put them in some heel lifts, take the pressure off that forefoot, that also helps out. But here, simple taping. I like to use a Coban, or like I tell my patients to get those children's headbands, like the flat wide ones. You can crisscross it over the toe and bring it around the heel. There's devices that are made specific to this. You can obviously tape them down. Taping, obviously, if you're doing it daily, becomes really tender and raw to the skin sometimes. So that's why I like the little other tricks better. And then the other thing is shoe gear modification. Avoid flats. Avoid flexible shoe gear. There's a huge trend right now for barefoot running, feel the ground. The shoe commercials, you can kind of see them rolling their shoes up. So many problems are happening because of it. Well, thank you, Nike and all those. But
right. Should send them, thank you cards.
But as far as shoe gear goes for these type of problems, we do like to use rocker bottom shoes or stiff shoes, hiking boots, construction shoes. I have patients who say that they feel so much better in their construction boots, but it's not like they can wear those all the time. The rocker bottom shoes are nice because obviously it's a stiff platform, and that rocker bottom to that shoe allows that functional movement rather than flexing across those toes.
And if you're catching these early, where they have that pinpoint capsulitis or that pinpoint pain, then the offloading and the other things are really pretty effective because they haven't had the deformity, they haven't had the architectural problem. And so, that stuff works so much better when you catch it early.
Yeah, and a lot of the times, so patients will put up with this, and that's when we catch it lower towards the end of the problem. That's the hard part. We'd rather you come in, but most people are like, oh, it's a toe problem. It'll go better. I'll wear different shoes. Oh, it's probably because I wore dress shoes on Sunday, They
rationalize it.
Yeah. What else? All right. Boots, shoes, surgical shoes, some orthotics. I do love orthotics for these, even after the surgery.
Yeah.
The surgery, aside from fixing the problem, this is something that we can do after the surgery to make sure that it doesn't, hopefully, come back or affect the other toes. You can do steroid shots. I'm not a big fan of steroid shots. I'll do maybe 1 or 2. I don't like to go too aggressive with plantar plate ruptures with steroids. Yes, it brings the inflammation down. Yes, it alleviates some of the pain, but it's a steroid. You got to think steroids do hinder somewhat of the healing process when we're talking about plantar plate repair or any repairs.
So the second ray cutout, the second med head cutouts, those are helpful. Yeah. When you catch this and it's just capsulitis, I think those are great.
Yeah. All right, surgery. So this is probably the most common type of surgery that people do for plantar plate repairs. This is the I typically do. We'll go in and we'll kind of walk through these pictures right here. You can see that plantar plate has been injured. Typically, we'll release it all the way from the plantar aspect of the proximal phalanx space, and we'll go back and we'll do our osteotomy here, our wild osteotomy. Pretty much most of the time when we have these problems, we're trying to balance that second metatarsal in relation to the other metatarsals around it. The goal being a very slight parabola. A lot of the times with these, you'll notice that the second metatarsal is long, and that's one of the predisposing factors to these. So we'll go back, we'll shorten the metatarsal, we'll fixate them using our screws or pins or whatever people wanted to use. And then we'll talk about going in and repairing this directly using grafts, using tendon synthetic grafts, or whatever you want to use, whatever people want to use nowadays. But this is kind of...
We were using Artelon as a replacement or an
your
augmentation.
synthetic, and they work great. You're bolstering that support there.
It was popularized by my buddy Rich Adams from Granbury. Give him a shout out.
So here's the wild procedure we were talking about. You can kind of see in this case the patient had a long second metatarsal. They went back and they shortened it some, got everything else in good alignment.
Well, that got longer when they did the bunion.
That bunion, yeah.
That shortened the first ray. So that definitely doesn't help.
Yeah, this procedure is as straightforward as it gets. Literally go in, we do a transverse cut all the way across, pretty much parallel to the ground. We'll shift it back, fixate it 1 or 2 screws, and we'll nip off the end that's too long. That also gives us some space in surgery while we're in there to help bring some of that slack back from that plantar plate so we can attach it if we're doing it the direct repair style. So when we're talking about the direct repair style, we're pretty much taking that plantar plate. There's, so many different suture patches on the market. Hat Trick, Vilex, Hat Trick, Cobra, Viper, they all have these funny names. Scorpion, yeah. Gravity, there's a bunch of different ones. But anyways, the purpose is they're suture passers, and then they give you a little fixation technique to the base of the proximal phalanx. Single fixation, you can do crossing where you tie it at the top. You can do the knotless suture anchors. There's tons of different ones, but you'll see commonly that the suture will be passed into the base of the proximal phalanx, and that's just because the tear is so close to the base.
So what is your opinion on the fiddle factor with those systems?
High
fiddle factor?
So much fiddle. They give you this claw-like looking device, and it's, all right, how can I explain it? It's as big as the end of a Sharpie, right? Like the back end of like a Sharpie, right? And you're putting it in there, and the joint space is already this much, and you're trying to grab almost like a little piece of tissue paper. It's so difficult.
Yeah, I think the barrier to entry on that thing is the fiddle factor on most of those sets. Yeah. And so I kind of I used them for a while and then kind of went back to doing plantar.
Hands.
Well, just doing a plantar approach.
Yeah. So I do have that in there. Yeah. I've actually, I've only done them a couple times, the plantar approach.
I like it because I can see the whole thing's right out in front of you.
Yeah.
You can repair it with,
How do you do your wiles then?
You just go through the top.
Oh, okay.
You still go through the top. And I don't do wiles on every one of these.
Yeah. If it's needed.
Yeah, if it's necessary, you just go through the top.
Yeah. All right.
Which is probably a disadvantage because you're doing 2 incisions, but man, it reduces the fiddle factor.
Yeah. And then you have a direct visualization. It's direct repair. Yeah. Rather than trying to do surgery on the bottom of the foot
from the top
through the top.
Which I can see why it appeals to a lot of folks. I just think the fiddle factor for me was just tremendous. Turned me off.
So here's the plantar approach.
Yeah.
So this is
right
exactly what Dr. D is talking about.
Is it hard to see the rupture? No. It's right in front of you.
So this is the rupture right before dissection. This is your tendons that they pulled over. This is the rupture, the tear. What they did was ellipse out the rupture, and then they do a direct repair. And in this case, they also do the flexor tendon transfer. And if you want to do your synthetic grafts, if you want to do your Artelons, if you wanted to do umbilical cord, whatever you want to do, you can do it on this part also.
I think the original idea for a lot of those other sets was to avoid a plantar incision.
Yeah, that's exactly.
Plantar incisions heal beautifully.
Yeah, if you do your lazy S style, so you avoid the
straight line.
Yeah, if you avoid the pressure spot. Right. Also, I think in this paper they were talking about doing an ellipse style up here, so the skin also helps bring it down, which is nice because I do those for my fifth toes quite often. They work wonderfully, and so what they do is they direct repair that plantar plate rupture using whatever type of suture they like. I typically would probably use absorbable for these, just because it heals up so well. And then you also have the other soft tissue components around it. Then you do the tendon transfer, where you take that flexor digitorum longus, and you obviously most of the times you're doing some type of hammer toe repair with these, and they'll tag it down to the base of the proximal phalanx. So they'll find the flexor, they'll bring that toe down just slightly, so you have a little bit of tension on there, and they'll direct repair it. Then obviously they'll bring up soft tissue around it, make sure there's no angular deformity. But yeah,
and these are tiny anchors. These are like 1.5 millimeter.
Tiny.
Arthrex corkscrew anchor is my favorite. That looks like a MyTech.
Yeah, look how tiny that anchor is.
Yeah.
I mean, think how tiny this bone is. And
Yeah.
think how much smaller that anchor is.
So it's, I think that's an effective way to do it as well. I find it quicker, faster, better.
There's the incision. I don't know why that
that's
was on a separate
exactly the incision I use.
Yeah.
Yeah, it's beautiful. And he looked great.
Why is this? There we go. All right. So here is the Artelon style. This is shown from the top, or if you can use whatever other.
Where you find these gifts, crack me up. Oh
so in this case, they did the crossover style where they take it from the metatarsal head. So metatarsal head, they put a drill hole, they bring it down and around. So they bring it down and around, pretty much making your own plantar plate. Same thing as before. Instead of directly going from the bottom, they have to loop it under.
And this one, that's the actual Artelon.
That is Artelon.
Yeah, I was going to say that. That's exactly the way we were doing it.
Yeah. And it works great. They'll tag down the toe. They'll bring it back to where they feel like the tension is appropriate, and then they'll tag it up top.
You can dial in your physiologic tension.
Yeah.
And that material is really interesting because it'll hang around for about 7 years.
Yeah, and then it allows a scaffold for your body to kind of.
Your body will replace all that with its own tissue over time, which I think is nice.
Yeah. Here it looks like they did a little arthroplasty also.
Yeah.
A little hammer toe repair.
Mm-hmm.
All right. A lot of times after these type of surgeries, I'll leave a K-wire in there to kind of hold that correction. Yes, we did everything around it, but everything we did around it is soft tissue, and it's a balancing on the metatarsal head.
Right.
So here's the before. Here are some afters. Here you can kind of see that they did quite a bit of bunion surgery or hammer toe surgery. These are different patients, but
fused that great toe joint, so that must have been a pretty significant bunion or maybe a redo.
Yeah. But anyways, that K-wire will hold that correction. Typically, we'll leave it in there for about 4 to 6 weeks. I don't know how long do you how long
Yeah, about then, but I try not to let mine do what that far right picture is doing.
Yeah, that looks like that. They caulked it on something. That's when patients take the shoe off or boot off, and I'll catch that little hook on the end. And that's why a lot of the times I'll put like the sponge over, or use those little balls.
We use the Jergens balls.
Balls, yeah. The risk of those hooks, obviously, is going to catch on something. But anyways, the K-wires will stay in. They'll have them in there for about 4 to 6 weeks. Once everything kind of looks stable, you kind of take them out, pull them out, and presto changeo. Now you have a balanced foot. The recovery for this is pretty straightforward. Some people keep them off weight bearing depending on the procedures they're doing. Some people keep them on these 4-foot rocker shoes, boots, whatever, casts. A lot of the times after surgery, I will recommend patients to continue doing the splinting just as an additional stability. They can use tape. They can use the fancy splints. I think there's even like what's that called? It's like a little device that kind of like CPA machines that they use for knees.
Oh yeah.
What's that one for the toes that they use? I totally should have put that in there.
Yeah, I know what you're talking about. It's continuous passive motion, CPM. Yeah. The other thing I think though is what you're trying to accomplish with that is you're trying to stretch that scar.
Yeah.
So a lot of times they've had enough contracture in the skin that's pulling the toe up, so you can stretch all that. So that is I think that's a valid use of that technology to try to stretch that dorsal scar, so you don't allow the toe to get pulled back up.
Yeah, and then afterwards, I 100% recommend them getting to orthotics. Simple. It's like a little insurance policy to make sure that nothing like this ever happens again.
There were forces that led to all of these deformities that you need to neutralize, and orthotics are a good way to do that.
Yeah, you didn't catch it on something. Most likely, you didn't catch it on something.
Right.
It's not like you walked and caught like the carpet or something and it tore something. This happens to wear tear deformity. If it happened on one side, obviously it can happen on the other side, or it can happen on the other toes next to it. The orthotics, simple insurance policy to make sure that this doesn't happen again, and patients are usually a lot more comfortable with them regardless. But yeah, that's plantar plate repair as far as basic surgery.
Yeah.
If you wanted to go really in depth, we can talk about like hemi implants and fusions, and that's when they get really, really bad and everything else is failed. But this is pretty much the go-to styles for plantar plate repair or your crossover toe deformity.
Very nice. I think that was a great discussion of a very difficult problem. Dude, you kill me. That's awesome. Well, Dr. Hussain, thank you very much for that. And this was our, let's see, how many episodes have we done now?
The 31st episode.
31st episode. We are in the first week of September, the first day of September in 2021, still recovering from COVID. Hope everybody's doing okay out there. And please leave us some comments, like and subscribe. And we'll see you next time on the Pod Doctors.